and mucormycosis in COVID-19 patients by Dr. Mehreen Nasir. I will hand it over to you, Dr. Mehreen. Off you go.
Bismillahirrahmanirrahim. If you cannot do great things, do small things in great way. My topic of research presentation is Aspergillosis and mucormycosis in COVID-19 patients, a systematic review. I am Dr. Mehreen Nasir, postgraduate resident in Department of Community Medicine under supervision of Professor Saira Afzal. Background. We all know that fungal infections spread through spores of fungi that are normally all around the environment in air, and normal healthy people continue to breathe in them without being affected by these spores. And getting infected with this fungi is rare occurrence, but people who are already immunocompromised and suffering from lung diseases are more vulnerable to acquire these devastating pathogens. Introduction. COVID-19 pandemic, we all know, started in China and subsequently spread throughout the world at an alarming rate. Aspergillosis and mucormycosis are devastating fungal infections which have increased in frequency in COVID-19 patients. So the objective of my study were three objectives. Number one was to identify the risk factors of aspergillosis and mucormycosis in COVID-19 cases, and to calculate case fatality of aspergillosis and mucormycosis in COVID-19 cases. And my third objective was to calculate incidence of aspergillosis in critically sick COVID-19 cases, which included mechanically ventilated and non-mechanically ventilated COVID-19 cases. Methods. A systematic review was done according to Prisma guidelines for extensive literature search. Articles on aspergillosis and mucormycosis in COVID-19 patients between 1st January 2020 to 15 June 2021 were searched, and 4 databases were used for searching articles, which were Google Scholar, ParkMedinet, PubMed, and Medline. In each database, Boolean operators and keywords used were aspergillosis or mucormycosis and COVID-19. Eligibility criteria. My inclusion criteria were articles of mucormycosis and aspergillosis in COVID-19 patients which have mentioned risk factors or case fatality or incidence of aspergillosis in critically sick COVID-19 patients, and articles which focused only on treatment, management, surgical options, autopsy, post-mortem, histopathology findings, molecular detection were excluded, and articles with languages other than English were also excluded in our research. Article selection. For selection of articles, 2 researchers independently screened the articles on basis of abstract during the first phase, and the articles meeting the eligibility criteria were entered in phase 2 of screening, and in which full text of articles was read by both reviewers independently. This is the Prisma flowchart. During this, we searched for that total number of articles was 2706, and after removing duplicates, we got 2650 articles which were screened on basis of abstract, and we found 160 articles. And after eligibility criteria, and when both reviewers independently read the articles, 40 articles were included in the systematic review, in which 21 were from mucormycosis and 19 from aspergillosis. Data extraction and synthesis. Data was extracted from eligibility studies, which included author's name, age, gender, site of disease, comorbidities, and case fatality. Incidence of aspergillosis in COVID-19 was also extracted, and data was entered in Microsoft Excel. Bias assessment. As we all know that the quality of article matters a lot while doing systematic review. So we calculated the bias assessment was done which were used for calculating incidence of aspergillosis. They were either prospective or retrospective cohort studies, and the quality of those articles were assessed with Joanna Briggs Institute critical appraisal tool for systematic reviews. Coming to the results. This is a table of results of mucormycosis. 21 case report and case series were included, and total number of cases was 48. The mean age was 56.3 years with standard deviation of 15, and there were 36 males and 12 females. It can be seen that the males are more than females. However, the outcome of males and females in terms of case fatality was not different. Chi-square test was used, which was 0.133. And the major risk factor was diabetes, chronic kidney disease, ischemic heart disease, transplant, organ decompensated liver disease, and hypertension. And the most common site was rhino-orbital mucormycosis, but cutaneous mucormycosis, gastrointestinal, and pulmonary mucormycosis were also noted. Now, again, we can see the steroid use was fairly common in the cases. 45.83 were using steroids for the COVID-19, and 33% were not using steroids, and in 20.83%, steroid use was not mentioned. Case fatality was our second objective. The combined case fatality of 48 cases was calculated to be 52% in cases of COVID-19 developing mucormycosis. Now coming to the results of aspergillosis. Total number of articles included were 19, and the risk factors were diabetes, hypertension, steroid use, heart disease, chronic obstructive pulmonary disease, malignancy, and chronic kidney disease. Again, the gender distribution showed that there are more males as compared to females. This is a table showing the combined case fatality of aspergillosis. Out of the total 708 patients, 363 patients died, which is 51.2%. Now, results of my third objective, which was incidence of aspergillosis in critically sick COVID-19 patients, which included mechanically ventilated and non-mechanically ventilated cases. This showed that the incidence was 9.3% with confidence interval of 3.93 to 14.67%. This is a forest plot showing the studies included, and their mean percentage is 9.3%. Now coming to the discussion, the number of males is more than females, and this finding is consistent with the number of previous studies, but the exact cause of gender disparity is unknown, and studies are being done to find out the exact cause of gender disparity. And diabetes was the most common risk factor in other systematic reviews of mucormycosis and aspergillosis. And this study reported higher mortality, which was 52% in COVID-19 with mucormycosis and 51.2% with aspergillosis in COVID-19. This may be because of the cases of mucormycosis and COVID-19 co-infection has resulted in a higher case fatality. Other systematic reviews have reported combined case fatality of around 45 to 48%. So their co-infection is causing higher case fatality. Conclusion: case fatality from aspergillosis and mucormycosis in COVID-19 cases is quite high. Diabetes is the most common comorbidity in cases of COVID-19 developing mucormycosis and aspergillosis. And the incidence of aspergillosis in critically sick COVID-19 patients is around 9.3%. Early screening and prophylactic antifungals can improve the prognosis of this disease. These are the references of my presentation, and thank you.
Thank you very much, Dr. Mehreen. It was a very good presentation. If there are any questions from the participants, you can drop it down to the chat box. I cannot see any questions at the minute, but if there is any questions, you can drop it down and we can ask Dr. Mehreen Nasir later as well. Is it any hands raised? Any questions? Okay. Thank you so much. We will proceed to our next presenter.
Yes, Dr. Khunsa Junaid is with us.
Thank you, Dr. Saadia. So the next presentation is from Dr. Khunsa Junaid, which is on substance abuse and mental health issues in HIV. Over to you, Dr. Khunsa.
Where are the presentations? PowerPoint have it. No. कौन सी आपकी? This one? ये share screen हो रही है कि नहीं? ये share screen. नहीं. Share screen कौन सा लिखूं? This one? Presentation
ये आपने कर दिया वैसे सर नहीं यहाँ पे हम ये करने शेयर हो गया ये शेयर और ये स्क्रीन शेयर है बस उनके पास वो कर सकती है
Dr. Mahwish, should we start?
Please. Yes, please.
Okay, thank you.
Bismillahirrahmanirrahim. My name is Dr. Khunsa Junaid and I am postgraduate resident in community medicine in Gadol Medical University. Today my topic of presentation is substance abuse and mental health issues among HIV or AIDS patients, a systematic review and meta-analysis. There is no health without mental health. Learning objective of today's presentation is introduction, methods, results, discussion, conclusion, and references. There is high prevalence of substance abuse and psychiatric disorders like depression and anxiety, bipolar disorders, post-traumatic stress disorder among HIV infected individuals. During their clinical management, patients with HIV or AIDS must consider for the triple diagnosis, which is the HIV/AIDS, psychiatric issues, and substance use disorders. However, various studies have focused on this issue, but there is a deficiency of comprehensive literature on the triple diagnosis. According to US recent source 7.7 million adults have co-occurring mental and substance use disorder, and of the 20.3 million adults with substance use disorder, 37.9% also had mental illness. And among 42.1 million adults with mental illness, 18.2% also had substance use disorder. Primary objective of this systematic review and meta-analysis was to find out the pool prevalence of common substance abuse and mental health issues or disorders among HIV or AIDS patients worldwide. Methodology. Preferred reporting system and preferred reporting systems for systematic review and meta-analysis. Prisma Checklist 2020 were used for data reporting and analysis. Information sources such as PubMed, Medline, PubMed Central, Google Scholar, PsychoInfo, and PubMedinet were searched for publication for January 2010 to May 2001. We also performed a literature using direct websites of local journals. Eligibility criteria of this result include inclusion criteria. It includes all observational studies such as cross-sectional study, case control study, cohort study, with original data, prevalence of substance abuse and psychological distress, mental distress among HIV or AIDS patients published in English from January 2010 to May 2021 were included. Exclusion criteria. Article was excluded on specific ethnic group, pathophysiological conditions, dementia, organic mental disorders, and developmental delay among HIV or AIDS patients were not considered for this systematic review. Main focus or outcome variables are divided into two types: mental health indicators, which include depression and anxiety and psychological distress, established on diagnosis of healthcare worker or used a validated scale with well-defined cutoff. Indicators of substance abuse include overall lifetime or current prevalence of any substance abuse. Two variables mainly focus in the substance abuse is alcohol and tobacco smoking. Lifetime prevalence was described as the proportion of persons who have ever used any substance in his or her life, whereas current prevalence was described the percentage of persons that have ever used any substance over the past 3, 6, or 12 months period in his or her lifetime. For literature, search various Boolean operators and or truncation, which is indicated by symbols, and combination of medical subject heading mesh terms were utilized. Methods of quality assessment. Checking the quality of included articles, a modified and adapted version of Newcastle-Ottawa scale separately for case control studies and cross-section studies were applied. Statistical procedures. MedCalc meta-analysis software package version 20 was used for data analysis. In this, the random effect model for meta-analysis was used to quantify the overall pool prevalence of mental distress and substance abuse disorder among HIV or infected patients. Prevalence estimates were reported with 95% confidence interval. And to checking the publication bias, a funnel plot and eager regression tests were used. And statistical significance was set at less than p-value 0.05. Results. 19 study out of 237 retrieved studies consist of 40,631 total HIV infected participants met over inclusion criteria. Majority of study population was from Africa, and according to bias assessment, 78% studies had a low risk of bias, whereas only 4% studies have moderate risk of bias according to Newcastle-Ottawa scale. The overall pool current prevalence of substance abuse was 65% and depression was 30.1%. respectively. There was no significant publication bias suspected in meta-analysis as p-values greater than 0.05, but substantial heterogeneity, I-square more than 80% was observed in the studies. Prisma table flow diagram, total record identified 237, and then after removing screening, we get screen 189, after records excluded and for retrieval process 30, and further reports assessed for eligibility, and after applying inclusion criteria in included studies, we include only 19 studies in review, and also include reports in our final meta-analysis is 19. This is the study characteristics table, which is shows that some studies are cross-sectional, some are cohort study, and studies are conducted in institutional community-based study. And as we see that most of the area were from Africa, and some are Togo, Washington DC, USA, Nigeria. And if we see the mental health indicators, the most of depression is most reported mental health disorders, and then psychological distress, and alcohol or substance abuse is also most reported in the studies as compared to cigarette or tobacco smoking. Similarly, in 19 study, as you can see that the most of the studies from the African region, and the most reported psychological, most reported the alcohol, and it most reported substance abuse. This graph shows the forest plot of the prevalence of substance use among HIV or AIDS infected patient meta-analysis. As you can see graph or forest plot, it is indicated by box, and the box indicate the point estimate that each study indicate or weight given in each study in meta-analysis. And rating from this box is indicate 95 confidence interval. If we see the forest plot of prevalence of current substance abuse, see that the most weightage given by the NK20 et al. Studies and and Zhang C et al. Weight 43, and Singh NK et al. Has 42%. Whereas the least weight give in Brown et al. And you can also see from the statistic it is weight is 0.9. The last column shows the total effect by either through fixed effect or random effect model, and it is the overall meta-analysis or included study which is indicated by diamond. The height of the diamond indicate pool prevalence, which is through fixed effect is 14%, and through random effect model is 21.25%. And the indicate side indicate the upper confidence interval, lower confidence interval, which is 11.52 and 41.8. Therefore, the pool prevalence is 25, which is the prevalence of current substance among HIV/AIDS patient. Heterogeneity test Q is 1150 and significance level is 0.01. And I-square is 99, which shows significant heterogeneity is present. If we see publication bias funnel plot, we see that there is no significant publication bias, which is indicated through inverted funnel plot, and it indicates that 95% of the of studies are fall under the funnel plot. Therefore, and the p-value is 0.112 and it is greater than 0.05, which indicate that there is no significant publication bias in our study. There is another first sort of prevalence of depression among HIV or AIDS patient meta-analysis, and if we see, you can see Singh NK 2020 and Pog J et al. Are the give maximum weightage in the meta-analysis of mental health disorders. And if we see the weight 12.83% and Singh et al. 12.86% give the maximum weightage in the meta-analysis. Whereas the least weight which is given by the study is 6.98. Which is indicated through the Higoras CV et al. And its weight is 5.25%. And according to heterogeneity test Q, the I-square is 89.84%, which indicate that significant heterogeneity is observed. And if we see the funnel plot of publication bias for the prevalence of depression in HIV or AIDS patient, there is no significant publication bias because most of the studies as indicated from by the dot are fall under the funnel plot. And the p-value is also 0.5312. And Eager test is as indicated, which is used, Eager regression test which is used to estimate the publication bias is also p-value is greater than 0.533. Therefore, no publication bias was also suspected in the prevalence of depression, and therefore we through random effect model or pool prevalence of depression is 30.3%. Discussion. The overall pool prevalence of any substance abuse and depression among HIV/AIDS patients were 25% and 30.31% respectively. According to the results of previous studies, 20 to 50% of HIV/AIDS patients have co-occurring psychiatric and substance abuse disorders. The prevalence of current admissions were reported in 15 studies in our studies ranging from 1.9% to 77%, than current tobacco smoking, ranging from 1.9 to 51.5%. This finding was consistent with the finding of previous studies that consumption of alcohol is greater among the HIV patient than the general population. Strengths and limitation of our study. Strength. Due to strict following of Prisma guideline, the current systematic review reported the representative estimate. To aid the accessibility of evidence for concerned policymaker, the prevalence of common mental disorders and substance abuse among HIV AIDS was comprehensively reported. Two authors independently collected data to lessen the probability risk. Limitation. Current systematic review and meta-analysis was under effect of substantial heterogeneity. We combine a small number of studies in the meta-analysis which may affect the estimated CN. The result did not show the prevalence of lifetime substance abuse disorder because of limited data. Insufficient data was available on lifetime prevalence of substance abuse in the studies, and most of the reported is the current prevalence. Conclusion. The current systematic review and meta-analysis indicate that the overall pooled prevalence of any substance abuse was 25.13%, and the prevalence of depression among HIV or AIDS patients was 30% compared to general population. Therefore, policymakers should be designed strategies to limit extensive utilization of substance abuse, and there should be incorporation of psychosocial provision and mental health services with curative services of HIV or AIDS. References and thank you.
Thank you very much, Dr. Khunsa. It was a really interesting topic, and the presentation was really, really good. Any questions from the audience? I can't see any questions in the chat box. Please, if you have any questions, you can drop down into the chat box. If there is no hand raised, no questions, then probably we can move to our next presenter.
Thank you so much. Now I'm going to screen for the screen sharing. It's my turn. I'm Dr. Sadia Rafiq.
Yes, so our next presenter is Dr. Sadia Rafiq, and the presentation is on prevalence and predictors of stunting in children. I'll give you some time to start sharing your screen, and once you have shared your screen, you can start presenting.
Okay.
Over to you.
Thank you so much. इसमें कोई भी नहीं है नीचे प्रेजेंटेशंस में ये वाली है हाँ जी मेरा इसमें पड़ी नहीं
आपकी ये
नहीं है इसमें खुली नहीं हुई
जिसमें खुली नहीं है आपकी पड़ी हुई कहाँ पर एक मिनट मैं पूरे डेस्कटॉप पे ले लेता हूं
Oh, this one. Thank you. Thank you. So much. और what is
ये इसको बहुत लगा वो नजर आ गई ना
Can you all see my screen?
Yes, your screen is visible, Dr.
So should I start?
Yes, please.
Okay. Bismillahirrahmanirrahim. Rabbi zidni ilma. Quote of the day. Success is not final, failure is not fatal. It is the courage to continue that counts. Assalamu alaikum everyone. My name is Dr. Sadia Rafique and under the supervision of Professor Dr. Saira Afzal, today I'm going to present Prevalence and Predictors of Stunting in Children under 5 years of age, a systematic review and meta-analysis. Learning outlines, introduction to stunting, methods, results, discussion, conclusion, strength of the study and the recent advances. Learning outcome. At the end of presentation, participants would be able to describe stunting, its prevalence, predictors, and recent advances. As you can see, the different types of undernutrition. It's a normal height and stunting is low height for age. Introduction. Stunting is defined as the percentage of children aged 0 to 59 months whose height or age is below -2 standard deviations, which is moderate and severe stunting, and -3 standard deviations, severe stunting from the median of WHO growth standards. Childhood as an important growth period has huge impact on the future development of the child. 70% of the stunted growth occur within the critical window, which is 1,000 days of life from conception to first 2 years of life, 0 to 23 months. Stunting results in high risk of morbidity and mortality, leading from poor performance and intent quotients, emergence of chronic diseases, and ultimately leading to losses in economic growth and social development of the country. Stunting cycle. As a stunting child leads to malnourished young girl, and she becomes a malnourished mother, and she delivers an underweight baby. And the cycle of stunting, like a vicious circle, goes on. Globally, stunting is a serious health problem, particularly in developing and low-income countries with a prevalence of 36% in Africa and 27% in Asia. In Pakistan, 43.7% of under 5 children are stunted, and it is positioned 3rd in the world, having 12 million stunted children at 5 years of age. The risk factors can be categorized into individual, which are maternal and child factors, household, which includes the water, sanitation, hygiene, wash, socioeconomic, and third are the community factors. And you can see in this diagram, wheel diagram, this is the child, household factors, and these are the community factors or other risk factors. Methods. Research search strategy. A literature search between January 2016 and May 2021 was done using databases PubMed, Medline, Google Scholar, and ArcMedinet. Various anonymous keywords in each database using Boolean operators and combination of medical subject headings, MASH. Terms were used with respect to include a large number of relevant articles, and the author used the term prevalence of studying children under 5 years of age and predictors and determinants and factors. Eligibility was evaluated, duplicates of articles were removed by 2 authors, and disagreement between 2 authors were resolved. After the full text assessment, 15 papers were found to be eligible and included in this final systematic review. As you can see, this is the flow diagram of literature and study selection. Initially, the identification total articles were 558 in these different databases, and then the records were removed, and the initial screening there were 367 articles, and after the records accrued, reports were not removed, and after then 23 was retrieved, and after the final exclusion criteria, only 15 studies were those who were included in this systematic review. Inclusion-exclusion criteria. Inclusion criteria, observation studies including cross-section studies and case control studies that refer to any causal and contextual factors of stunting growth as recognized by WHO context in English, conducted in African and Asian regions of the world. Exclusion criteria include children under 5 years of age with congenital anomalies, chronic diseases causing loss of appetite, and eating disorders were excluded. Data extraction. The following information from the selected 15 studies were extracted, which was author's name, publication year, study setting and design, size of a sample, child's age, mother's education, weight of the baby at birth, breastfeeding, socioeconomic status, and prevalence of stunted growth. As you can see, this is a chart having all the variables in it, including all the 15 studies. Statistical analysis. For data analysis, MEDCALC meta-analysis software package version 20 was used. Random effect models was employed to generate a pool prevalence and was presented at % and 95% confidence interval. I2 heterogeneity statistics were used to assess the heterogeneity and the excess of variation between them included and was reported as percentage. To present the result of meta-analysis schematically, forest plot was used. The Cock and Q test and I2 statistics were used to test heterogeneity in pool prevalence estimates. Results. Majority of the included studies in this systematic review were from the Asian regions and 4 studies were from the African region. Minimum sample size was 60 and maximum was 76,165, having mean 7,360, median was 324, and the interquartile range was 3764. Out of these 15 studies, 9 studies were used to assess the pool prevalence and 6 studies were prevalence of inhibited growth was estimated in 2 groups, children either less than 2 years or between 2 to 5 years. Pooled prevalence estimation. Out of 15 selected studies from different settings, 9 studies with total study participants were 98,226 reported with growth retardation under 5 years of age were included and meta-analysis was performed. As you can see, these are the total 9 studies which were included for the pool prevalence. So it was the sample size total, it was the proportion, and it was a 95% confidence interval. The forest plot of the prevalence of stunting in children under 5 years of age. These are the total of studies. This was the random effect. You can see the p-value, I2 agency was 99.3% and 95% was the confidence interval. The overall pool prevalence of total stunting in children under 5 years of age was 39.11% with 95% confidence interval, which was 33.017 to 45.39. A significant heterogeneity with I2 was 99.39%, 0.0001% was found among the studies. Discussion. Growth retardation is the most prevalent manifestation of the childhood malnutrition, and globally, 1 in 4 children under 5 years of age suffers from it. In our study, pool prevalence of stunted growth was 39.11%, and it is almost similar to one of the studies conducted in Ethiopia, which showed 38.3% retarded growth in under 5 years of children. Mother's education, one of the most frequent predictor, 80%, and one of the study conducted in Indonesia showed that the children of mother with low education level are at risk of retarded growth 1.9 times greater than the children of parents with higher education. Another important predictor, low birth weight, which is less than 2,500 grams in 60% of the studies, is one of the leading factors to determine the growth pattern after birth. One of the studies conducted in Indonesia showed that infant born less than 2,500 grams are 1.74 times more likely to be stunted than born with normal weight. Breastfeeding, 53.3% mother did not exclusively breastfeed their children for 6 months. And one of the study conducted in Mexico showed that the proportion of not breastfed children with stunted growth, 27.5%, was almost twice that of breastfed children, which was 12%. One of the predictors of the study with 53.3% showed that poor and lower middle class has a higher prevalence of retarded growth in children under 5 and is an indicator of chronic deprivation of nutrition. In this regard, socioeconomic status also plays an important role in it. Conclusion. In this systematic review, the pooled prevalence of stunting in children under 5 years of age was 39.11%. Regarding predictors, mother's education was one of the most frequent predictors with 80%, weight of the baby at birth 60%, predictors like breastfeeding and socioeconomic status were 53.3%. Literature search has showed that stunted growth is a result of or outcome of the interaction of multiple factors. The prevalence and predictors in this study can be used as informational material for the implementation of prevention and control measures effectively to address this issue. The way forward based on this research is that new community-based nutrition programs need to be established and upgradation of already existing nutrition plans to handle this problem at community level. Strength of the studies, age-wise comparison of stunting, high prevalence of predictors in African and Asian countries, study included but with good sample size more than 16, and identification of high prevalence under 2 years of age, which is reversible and preventable. Recent advances, the World Health Organization has a global nutrition target for reducing the number of stunting in children under 5 years old by 40% in 2025, and it will be all done by scaling up the prevention, maternal nutrition, support breastfeeding, and community support. According to World Bank document, early nutrition programs can increase school completion by 1 year. Early nutrition program can result adult wages by 5 to 50%, and children who escape stunting are 33% more likely to escape poverty as adults. And reduction in stunting can increase GDP by 4 to 11% in Asia and Africa. These are my references. I am the corresponding author, and thank you so much.
Thank you so much, Dr. Sadia. It was really informative, and honestly, after you were going through your presentation, I really could say that community education is the prime here. once the community is well aware, we can definitely try to achieve that goal set by WHO.
Yes,
Thank you.
so
It was
much.
very informative, really good presentation.
Thank you so much.
Thank you. So
Next,
our next presenter is Dr.
yes,
Amber
Amber.
Arshad, and her presentation is on ethical and security issues in using electronic medical records. Once you have shared your slide, you can start your presentation. Over to you.
Thank you. Bismillahirrahmanirrahim. Never regret a day in your life. Good days give you happiness and bad days give you experience. My name is Dr. Amber Arshad, and today my topic of presentation is ethical issues and dilemma of using electronic medical records and insecure services under supervision of Professor Dr. Saira Afzal. So, as we know that digitalization, global digitalization is trending nowadays, and the use of electronic medical records has increased. And the electronic medical records gives advantages to both the healthcare workers, the patients, and the other clinical staffs. And the electronic medical records, despite giving advantages, there are several moral issues that are raised, and that can be faced by using extensive use of these medical records. There are several barriers, and the barriers incorporate obstruction of medical care experts to do this in this modern design. The rising ethical difficulties and worries of the doctors due to the extensive utilization of electronic data are pivotal. Globally, the electronic medical record systems are evolving at a breakneck pace and potentially outpacing the capacity, especially the lower middle income countries, including Pakistan. And these challenges have been associated with the electronic medical record implementations with low budgets and low facilities and the supports by the different government organizations. So there were several studies that were seen in the literature review while doing literature review that from United States, Finland, Sweden, Ireland, Germany, and also from the Asian countries, including Pakistan, China, and Bangladesh, that documented several ethical issues related to the use of electronic medical records, mainly the issue of autonomy and informed consent, privacy and security and confidentiality of the patient data, the trust, the justice, and the equity. So the aim of the study, of this research study, was to classify all possible ethical concerns of the healthcare professionals who are engaged in medical practice and in research activities, and on a daily basis use these electronic medical record systems for sharing and getting access to the patient's data and patient information. So in the methodology, we systematically assess the literature to identify relevant literature on how electronic medical records can pose several challenges according to Prisma guidelines, and the following heading summarizes the methodology of the review. So in the search strategy, a systematic review was done by searching 4 databases: PubMed, Medline, Google Scholar, ParkMedinet, that were with including published articles between January 2011 to June 2021. And as keywords, broad terms with Boolean operators were used, like ethical issues, healthcare providers, electronic medical records, and digital health records. And the authors used narrative approach of Prisma Guidelines 2020 checklist. For the inclusion criteria, the observational studies, mostly the cross-sectional studies, the dissertations, the discussions, the editorials that were full text articles published in English language between the duration to January 2011 and June 2021 were included, whereas all identified studies like CAP studies, case reports, prospectives, randomized intervention studies were not the part of the study.
For the study selection, a complete text of studies was passed through identification and abstract screening. One author screened all the titles and abstracts retrieved by the searches, and the same author screened any full text publication recovered using the standard Prisma guideline checklist. And the other author collected the data from the included papers. This is the Prisma flowsheet showing the selection of studies. And total 314 studies were identified from the 4 databases. After removing 20 duplicate records, 294 records were screened for the eligibility criteria, and 240 were excluded on the basis of abstracts, the RCTs, the qualitative studies, and the defined exclusion and inclusion criteria. 54 studies were sought for retrieval, and these 54 studies were gone through the final inclusion exclusion criteria was applied, and 24 studies were finally included in the systematic review. For data extraction and synthesis, both the reviewers independently extracted data on the features that included studies with respect to country and year of publication and ethical considerations, including autonomy, generosity, non-maleficence, fidelity, and veracity. The extracted data were narratively assembled by explaining the research characteristics and ethical problems, and Microsoft Excel software was used for data extraction and synthesis. In the systematic review, a narrative approach according to Prisma checklist was used, and author did not perform any meta-analysis or qualitative synthesis of selected studies was done according to inclusion criteria, and hence the risk of and this bias assessment was done. From the 24 papers reviewed, authors identified or discussed the following ethical principles that are faced by the healthcare professionals using electronic medical records. This is the summary of the outcome of studies, and showing that of all these studies included in this systematic review, most of these ethical issues that were reported were or related to privacy and autonomy and confidentiality of the patient's data, followed by non-maleficence, justice, fidelity, and veracity. This is the forest plot for all the ethical issues that are reported in the selected studies, and our research shows that most reported ethical problems were reported to privacy and autonomy, followed by confidentiality, justice, beneficence, non-maleficence, fidelity, and veracity. Accessibility of electronic medical data of patients is helpful for healthcare providers, but some notable highlights should be kept in mind when utilizing the e-health applications. And most debated about justice, equity, fairness regarding patients' treatments, fair distribution of resources, equal chances to utilize facilities available must be kept in mind while using or applying this electronic medical record systems. So the results of our study were in line with the other studies that were quoted in this systematic review with autonomy, highlighting these several concepts of informed consents, right to self-determination, freedom, disclosure, and willingness. As well, along with autonomy, goodwill and non-maleficence was also seen in high percentages, highlighting several vital concepts like do no harm, do not kill, do not offend, and do not deprive. This study highlighted ethical issues like unauthorized access, disclosure of confidential information, a secure reach of patients' private data, and trustworthiness at the top. There were several limitations to this systematic review, as broad terms were used like ethics and ethical issues, resulting in the missing literature on the selected topics. Focused on we only focused the open access articles, so forcing many articles to drop out of this that compromise the quality of the user data. And a more precise and comprehensive description of topic would have probably given better data coverage if we included also the qualitative studies. So the conclusion is that many of the difficulties raised in this research and consistent with the frequently discussed ethical challenges that digital technologies create in healthcare, such as privacy, autonomy, secrecy, and justice. And this paper research provided a unique opportunity to examine the shortcomings of the healthcare system, physicians' practices, and patients' impression, and to discover methods to enhance it and to ensure the application of code of ethics. So new finding was that according to our assessment, significant reforms to healthcare systems, including moral adjustments, are required to address these ethical challenges. such as knowledge gap, informed consent, autonomy, privacy, and confidentiality. And these new findings implies that there is an insufficient commitment to ethical norms in clinical practice, especially in the developing countries, including Pakistan. And consent, privacy, secrecy are routinely disregarded due to the lack of robust monitoring and enforcement system by responsible authorities. Here are the references of my presentation, and thank you.
Thank you so much, Dr. Amber. This was a really important topic for this the research that you have done, because this is a problem in our health services and healthcare department. So really good presentation, really
Thank you.
impressive.
Thank you.
Any questions from audience?
Wait.
I can't see any question in the chat box, but if you want to ask any questions, you can drop them down into the chat box or raise your hands. If there are no questions, we will be moving on to our next presenter, who is Dr. Minaam Farooq. Presentation is on nomophobia, a phenomena in the undergraduate students. Once you have shared your screen, you are good to go. So over to you.
Bismillahirrahmanirrahim. Can you see my screen? Can you see my screen?
Yes, we all can see your screen.
Okay, great. So my name is Minaam, I'm a graduate from King Edward Medical University, and the topic that I'll be discussing is my research on nomophobia, its prevalence, and the analysis of its contributing factors in the undergraduate students of Pakistan. So what really nomophobia is? Nomophobia is a relatively new term. It was first coined in 2008 by a UK-based research organization called YouGov, and it is a compound word of three words. No for NO, MO, which means mobile phone, and then phobia, which according to the DSM criteria means having a fear or anxiety of anything. So nomophobia actually means if a person does not have a mobile phone, how he faces anxiety and frustration. How I got the idea. So when we were in third year, we decided to do a research, and we had no as guideline to what really our topic should be. So me and my friends, we started looking for topics. One of my friends is a freelancer, and then he told that he read an article about this new word called nomophobia, and we should basically be doing a research on it. So what we did was we studied a few databases like PubMed or Cochrane and Wiley Online, and then we thought that okay, this has a potential to be that we could do research on it, because it is a novel idea in Pakistani demography. So our study rationale that why we wanted to do this research was, firstly, it is a novel idea on the Pakistani demography, and secondly, also that currently in the DSM criteria, that is a Diagnostic and Statistical Manual of Mental Disorders, in the 5th edition that is currently in the market, this phobia is not in that edition, but it has been proposed to the American Psychiatric Association that in its 6th edition that it should be added as a proper medical disease, and inshallah we'll be seeing nomophobia in the 6th edition as a recognized phobia. Now coming on towards the aims and objectives. So basically we had 3 aims. First was that we need to have a bird's eye view on the prevalence of nomophobia among the undergrads. Then we also wanted to check the correlation with gender. And then thirdly, we wanted to determine the contributory factors and their prevalence on nomophobia. So this is a nomophobia questionnaire, which was designed by Yildirim and Korea in 2011. They are Turkish scientists. So they were the basic originators of this questionnaire and this idea. The structure of this questionnaire is like there are 4 subgroups, which will be the 4 contributing factors that I'll be telling later on. And there were 20 questions in total. And every question was scored on the basis of a 7 Likert scale, from 1 to 7. 1 means strongly disagree and 7 means strongly agree. So a minimum score could be of a 20, meaning that every question gets 1. And then the maximum score could be 140 if every question got a 7. So this is the structure of the questionnaire. Now factors. So there were 4 factors, like why factors, meaning that if somebody is saying that, okay, he is nomophobic, so what could be the reason behind it? If somebody says that I have anxiety or frustration if I don't have a mobile phone around me, then what could be the contributing factors? So there were 4 of them. First one is not being able to communicate. If they feel like they cannot communicate, if mobile phone is not close to them, then that was one factor that we tested on the questionnaire. Then second was losing connectedness, that dealt with the idea of having an online identity and losing it. If you don't have a mobile phone, then you cannot be actually online and show yourself that you are existing, right? And then third was not being able to access information. People get frustrated, people get uh, people get anxious when they don't have a mobile phone or an electronic device and they cannot be able to access information. And then fourth one was giving up convenience. In this, it was like they had the electronic device, but they did not have other accessories that come with it. For example, use of Wi-Fi or even use of SIM. They have a mobile phone, but they don't have all these accessories. So this was the fourth contributory factor. So we tested the participants, the respondents of our questionnaire on the basis of these 4 factors. Now coming on towards the material and methods. So our study was a simple cross-sectional study, and our study population was mainly undergrads from intermediate FSC to or O levels to university. And our study setting was online because it was done mid-COVID, around about 2 weeks in April this year. So we were all in the lockdown. So we had to go for an online questionnaire approach, in which we use Google Forms to disseminate the questionnaire along with a few questions that dealt with the demography. And we use different social media sites like WhatsApp, Facebook, Twitter, and Instagram to disseminate this among the participants. And now the sampling technique was snowballing. So actually we passed it on to people, and then they passed it on further. So there was sort of a domino effect. We had an exponential growth in the respondents, and this is how we increased the population size of our study. And then the data analysis we did was with 2 softwares, SPSS and then simple MS Excel. Now the results. So as I told you that our questionnaire could have a minimum of 20 score and a maximum of 140. So according to the score, it is classified or categorized as mild nomophobia, moderate, and severe. Mild scores from 21 to 60, like 20 to 60 for ease. And then from moderate is from 600 to 60 to 100. And then severe is 100 onwards till 140. And as you can see that 48% of the total responses fell in the category of moderate nomophobia, having a mean score of about 92.8, which is in between the 60 and 100 category of moderate nomophobia. So this finding was in conformity with other studies that were done in Nepal. One was done in Turkey and one was done in Spain, and they all had most of the population in their countries to have the scores in the moderate category. So this is a cumulative frequency histogram. As you can see that major peak is in between the around about 90 and within the 1 standard deviation of it. So this was our cumulative score, and this was the cumulative frequency histogram. Okay, so now coming on towards the gender distribution. When we studied the scores on the basis of genders, we found that females had a higher nomophobic score. That was also in conformity with studies, almost all the studies that have been done till date in different countries, that females tend to have higher score. One thing that I want to mention is that the scores of 90 and 94 are a little bit above as compared to other studies that was done, and the major limitation or the major cause of it was COVID-19, because people had a greater reliance on the electronic devices. So that is why they had a higher score on it. And why it is that we females had higher scores than males. So it is a domain that is still undiscovered, but there are a few propositions that have been given. And according to it, females culturally and socioeconomically, if we see in countries, females overall have a lower induction rate of employment as compared to males. And even if we see the undergrads age, the females are not like, they are not allowed to go outside home and have a lot of other extracurricular activities, and even like simply hanging out with friends. So what they do is that they basically do their studies or do their thing and then they go back home. So they're more reliant on mobile phones as compared to boys, which who according to our society are given more liberty to go outside and do other things too. So that was that was a reason behind having a higher score for females, but still it is just a proposition, and it is still a domain that that is undiscovered and needs a bit work to do. Okay, now coming on towards the 4 factors that I told, that there were 4 contributory factors that could contribute to nomophobia. So factor 1 was not being able to communicate. It means that a person, when he was answering some questions, so there were some questions that fell in the theme of not being able to communicate, which means that they were not they were far away from friends. If it made them anxious if they did not have a phone, and they couldn't contact to their friends and family. So this was one factor. If we see the table, factor 3, which means not being able to access information, this had the highest average score, which means that most of the respondents, they said that, okay, we are anxious, we are nomophobic because we are not being able to access information, which could be e-learning, because now we use a lot of our studies online through electronic devices. Then there also could be other things like if we want to see weather report or news, etc., we tend to go for the electronic devices. So that was what we found out when we ran the analysis that factor 3, that was not being able to access information, had the highest scores, and second highest scores were for factor 1, which was not being able to communicate, which means that the respondents, they said that, okay, it makes us anxious if we don't contact our friends and families. So this was the overview of the contributory factors. And then comes the limitation. So basically there were 3 main limitations. The first one was COVID-19, which I already told, that as it was done in the mid of the pandemic, I think in the third wave of COVID here in Pakistan. So so the scores that we got were a little bit more as compared to other studies that were done in other demographic setups. So that was first thing. And then comes the demographical limitations, as we are just dealing with the undergrads and only those people who had mobiles. So that limited our study to just that population. So this was a demographic limitation. And then comes the geographical limitation, which is because we are doing a research, like we are doing it in Pakistani population. So that is why we had a geographical limitation. And with this, I would just like to conclude that our study on nomophobia, we aim to provide this information and awareness regarding the mental health issue, that now an increased amount of the increased amount of reliance on electronic devices, it was a mental health issue, but now it is more of becoming an issue that is backed by statistics. So this is our conclusion, and that's it. And if there are any questions.
Thank you, Minaam. It was really, I would say we all have some sort of nomophobia, to be honest. The other day, I was lost on the roads because I didn't have a phone to go back home. I just came to Pakistan, that's why. So I think we all have some form of nomophobia. And it is really I'm really happy to see you doing this presentation, being a 4th year student. Is something really good. Thank you so much. So our next presentation is so the next presenter we have is Dr. Qasim Mehmood on e-health activities for decreasing stress among medical students. Once you have shared your slides, you are good to go. Over to you.
Assalamu alaikum. Can you see my slides?
Yes, we can see.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Qasim Mehmood, and I'm a fourth year MBBS student in King Edward Medical University, Lahore. The topic of my research is attitude of medical students of Pakistan towards e-health educational activities in improving their physical well-being, an assessment of their level of physical activity, a cross-sectional study. We have done this study under supervision of Professor Dr. Saira Afzal, who is chairperson of our community medicine department. So what is e-health? E-health is the use of electronic devices and software programs for the transfer of health resources. In the recent era of technological advancement, reliance on technology has recently been increased, which has led to unhealthy attitude among young population, especially medical students. This has led to different prevalence of different diseases like cardiovascular diseases, stroke, diabetes, and joint problems in young population, especially medical students. Electronic media, other than its role in recreational activities, it can be used in making applications or web-based technologies in health management and provision of health solutions. Rationale was, despite recent advances in healthcare services around the globe, there is still a need of a proper e-health educational program, which can aim physical as well as mental well-being of medical students. The aim of our study was to evaluate the attitude of medical students of Pakistan towards e-health educational activities to improve their physical and mental well-being and to assess their level of physical activity. Objective of our research was to evaluate the attitude of medical students of Pakistan towards e-health educational programs to improve their physical and mental well-being, and to assess the level of physical activity among medical students, and to study the relationship between their level of physical activity and obesity among them. Now coming on to methods, our study design was cross-sectional. Sampling technique was a non-probability purposive sampling. Setting was medical students studying in different private and public sector medical institutes of Punjab, Pakistan. Study was done in 3 months. Sample size consisted of 466 medical students. We included on a criteria medical students from first to final year MBBS studying in different private and public sector medical institutes of Punjab, who have given consent to participate in the study were included, and those who haven't given consent and non-medical students were excluded from the study. Data was collected by making a questionnaire. It was based on IPAC. IPAC is International Physical Activity Questionnaire. IPAC is a long questionnaire consisted of 16 to 17 questions, but we have used a short version of it. We have devised it according to our needs and designed a questionnaire. We circulated the questionnaire among different medical students studying in different institutes. Via WhatsApp, Facebook, LinkedIn, Messenger, etc. Data was analyzed and processed using SPSS. Qualitative variables were represented as frequency and percentage, and quantitative variables were represented as mean with standard deviation. Now moving on to results. This slide is about basic characteristics of our study participants. Out of 466 respondents, 55.2% were male and 44.8% were female, with a male to female ratio of 1.23. Most of them were in the age range of 20 to 22 years. 84.1% of them were studying in public sector institutes, and 15.9% were from private sector medical institutes. 86.1% were from urban setting, and 13.9% from rural background. This is very important slide. It's a part of a study which is based on International Physical Activity Questionnaire. It's 6 questions which assess the level of physical activity. It's the low-level physical. In low-level physical activity, we have included walking and sitting. So out of 66, only 37.8% engaged in vigorous physical activity, and most of them were males. 45.7% of them were engaged in moderate level physical activity, and walking and sitting was categorized as low level physical activity according to IPAC, International Physical Activity Questionnaire. 89.7% of them were engaged in low physical activity, which is sitting, and almost all, like 9% of them were engaged in sitting on daily basis. Vigorous physical activity is that physical activity which takes vigorous effort of us and makes us harder than normal to breathe. So you can see, as we increase the level of physical activity, the number of respondents are decreasing, which can we can interpret that the most of the students are not engaged in physical activities. The impact of this can be shown on their BMI. We recorded height of participants in meters and weight in kilograms, and BMI was calculated from them. It was then divided into normal, overweight, obese, underweight, etc. Most of the participants were in the normal BMI range, which is 18.5 to 24.5 kg per meter square. Less than 18.5 is underweight, and 13.1% of them were underweight, and above 24.5 is overweight, or we can say above normal, and 125 of the participants, which is 26.9% of them, were having normal above normal BMI. They were categorized into overweight and obese accordingly. Mean BMI of the participants were 22.7% with a standard deviation of plus minus 4.34. Out of 125 which were above normal, 67.2% weren't engaged in any vigorous physical activity, which is a clear association. So this was the part of questionnaire which assessed the attitude of our study population towards e-health educational activities in improving their physical well-being. So we asked the participants whether they know about the term e-health, whether they believe that e-health educational activities can improve their level of physical activity, or they have ever used any health educational program in their life to improve their physical well-being. So 56% of the participants recorded that they know about the term e-health, and almost all of them, 80.5% of them, agreed on the notion that e-health educational activities can improve their physical well-being. But practically only 34.5% of them had practically used the e-health educational activities like mobile apps or things like that in their life. So our key findings were mean BMI was 22.7 with a standard deviation of plus minus 4.34, and 26.9% of the participants were having more than normal BMI, which is problematic. Obviously not for me, for them. Most of the study population, which is 80.5%, agreed on the notion that e-health educational activities can be helpful in improving their physical and mental fitness. But practically only 34.5% of them were engaged in using those activities in their daily life. Most of the reasons quoted by them to not use these activities or doing any physical activity in their life was their laziness or lack of interest or lack of time, which is a absurd thing that they can have time to watch video games, etc., and watch movies on bed, but they don't have time to do something which can be helpful for them. A small percentage of study population were doing moderate and vigorous level physical activity in their daily routine. Among those who were doing vigorous physical activity on daily basis, more male participants were there, and there was a significant correlation between level of physical activity and BMI of the participants with a p-value of 0.04. Limitations of our study was the sample size was small. We have included only medical students from Punjab, different medical institutes of Punjab, and only medical students are included in our study. If we have generalized it to other students or general population, it might have generalized results. and medical students having internet access was included as the survey was online. So these were limitations of our study. To conclude, I would say the drastic technological advancement has increased the reliance on technology, which has led to unhealthy attitude among young population, especially medical students. Technology can be used to develop e-health management program. In when they all know that the load of diseases associated with poor physical fitness is sky high. So study was aimed to assess the level of physical activity of medical students and to evaluate their attitude towards e-health educational programs in improving their physical and mental well-being. Most of the participants were aware of the term e-health and believed that e-health can improve physical fitness, but only a few of them were practically engaged in these activities. So awareness should be raised among them to spend more time on productive activities that can improve their physical as well as mental well-being. Last of all, I would say the quote of the day: eat right, move more, so that you can breathe easily. These are the references, and thank you.
मैं आ रही हूँ, बस ये conclude होने सेशन में आ रही हूँ. Okay. Qasim, मैं आपकी जगह आ जाऊँ मेरी जगह. Thank you.
Thank you so much. This was another good presentation, especially if we think about e-learning in terms of mental health problems that we use in UK. It's really helpful for patients if they can access resources on the phone. With this, we come to the end of our presentations for today. We have finished it a bit early, so a little bit more time for coffee and tea and cakes and sandwiches. Thank you so much, everybody, and a big applause for all the presenters for such a brilliant and informative presentation. Also, I would like to thank Dr. Saira Afzal, especially because of arranging all of these presentations in one place. That really helped us a lot in moderating this whole session. I would like to ask Dr. Saira if you would like to say something.
Okay, thank you very much, Mahwish and Dr. Haris. Thank you very much for your whole support, wholehearted support actually. And also thank you very much all the presenters who are sitting here, like Dr. Qasim, Dr. Minaam, and soon to be Dr. Inshallah. And also Dr. Sadia, Dr. Mehreen, Dr. Khunsa, Dr. Amber. They all have done a wonderful job. And all the participants, I can see more than 40 participants were with us during this session. And they have given their comments in the comment box. And this is wonderful to read those comments while I was sitting here. And this shows their interest in research. What I have seen over the years, the evolution is that more focus has been put towards research. Academic excellence is never possible without evidence, and the evidence always comes with the research and what latest technology is available to serve humanity. In the end, we all are here for the patient care, for the patient safety, and for better tomorrow. And we all pray for it, that our tomorrow must be better than our today. And all our presenters, especially Dr. Mehreen, she started with mucormycosis and aspergillosis, another something that we have not seen very often in our previous years. But COVID-19 has put another burden of the disease, that is of fungal infections. And we have seen a lot of cases of mucormycosis and aspergillosis, and how the different studies, they have reported them, and how the treatment should be revolutionized in order to cater all these new emerging problems and infections. It is something that Dr. Mehreen has stressed upon. Similarly, Dr. Khunsa and Dr. Amber, again, a very important guideline, that is the Prisma guideline, that is used for the quality assurance of the systematic reviews, and they have done it wonderfully. Again, Dr. Minaam, yes, and Dr. Qasim, beautiful presentations. You both have done a lot of good things, especially I can see that our reliance on technology is increasing day by day. And as you are young, you are becoming more used to the technology. But still, I remember those old golden days when we have less technology and we have more physical meetups and we have face-to-face discussions. Even when I'm talking here, I can see there are many people who are still using the technology in order to interact with me rather than having face-to-face conversation with me. Dr. Mahwish, you can't see here, but all the people, they are on their mobiles, and while I am talking live here, they all are using technology. So you can guess what is the reliance of technology in today's life. I wish we can have more time in face-to-face discussions. We can have more time in asking each other's problems and solving them. However, as the e-health, yes, there is another challenge. When when Qasim was talking about the people who are looking at the videos, but they are not very much into e-health physical activity, because the video can be seen while you are lying in the bed with the quilt on your face, and you can still see the video, but you can't do any exercise in your bed without removing your quilt or coming out of your comfort zone. So the most important thing that we have to come out of our comfort zone. We have to do more research to put more evidence for our own selves and for our own betterment. Another important thing, we have a telenutrition and teleobesity desk. So I would like Minaam and Qasim to become the part of this team who can contact all those people who have been reported as overweight and obese. I have noted the numbers too, that there are 32 who were obese and 93 overweight, and these all are medical students. They can be contacted on telenutrition and teleopathy desk to have a continuous follow-up. What is their daily routine, what diet they are taking on the daily basis, and how they are cutting off the extra pounds. And this can become an intervention study. So the next part and your next duty or your next responsibility is to join hands in order to put some evidence that is going to be an intervention study, because we know that it is higher up in level of evidence. Thank you very much, Dr. Harris and Dr. Mahwish, for giving me so much time. Thank you very much.
Thank you very much for your lovely talk as well. I think we can
I
conclude.
would say I would drop my contact details to both of them as well. They can do intervention with me as well.
you have one more participant.
Yeah. Also, I would say with the COVID era, this technology and then the Zoom and Teams meeting, everything has just come into play so much that we have lost physical and face-to-face contact with so many people. It's just on the phones and on the laptops now that we are seeing each other. So yeah, that's something really to think about. Thank you so much, Dr. Saira. You've been absolutely brilliant, as you have always been. Anything else anybody wants to ask? Anybody wants to say? You can raise your hand. Dr. Saira, anybody from your side?
Thank you. I think she is going to conclude the session.
Okay, हाँ मैं इस ऑफिस में जा रही हूँ, लेकिन आप सबको वहीं बुला रही हूँ. आप लोग तब तक कंटिन्यू करो अगर.
If there are no more questions, then probably we will end this session. So we will be continuing this meeting, because our poster presentation, which is the second part of channel 2, will be continuing from here. This will be at around 5:15.
Okay.
If you would like to join or visit the other sessions, because they're still running, as we have finished a bit earlier than we were thinking, we will resume our session here at 5:15, but you can visit the other channels and have a little break, have a cup of tea, have a cup of coffee, have some cakes. I hope there is something something yummy in the canteen as well, as it used to be when we were there. But yeah, or an Arcali is just a couple of steps away. Okay, so
thank you so much.
Thank you so much. You've been
Thank
a
you so
lovely audience and a lovely presenters, and everybody's has done a fabulous job. Thank you so much. We'll see you again at 5:15. Take care. Bye bye.
Okay, thank you, sir. Bye bye. Bye bye. Thank you. Leave कर लो।
म्यूट कर
जाओ बोल गई
Before we start, I would like to introduce myself. My name is Dr. Fayyaz. I'm one of the rheumatology registrars currently working in Northampton General Hospital in Northampton, UK. So we will be resuming our Channel 2 stream, and this will be the poster competition here. I can see a few of the panelists. I can see Dr. Turrab Arshad, and I can see Dr. Tabinda Duggal. Dr. Turrab and Dr. Tabinda, if you're able to hear me, could you kindly unmute yourself? I've made you co-host, so you should be able to unmute.
Yes, yes, we can hear you. Thank you ever so much. Good morning to you. Assalamu alaikum, everyone, or good afternoon in Pakistan.
Before we start, I think we can discuss a few things about this session. So I will be hosting this session, and Dr. Mahwish will be my co-host. He will be helping us with it. We have already shortlisted some posters, I think around 10, which you must have gone through. I've already sent the scoring sheet as well. So a few things I can describe is that once we will resume it around 5:15, and every presenter will be given a total of 5 minutes to present their poster. 3 minutes will be for presentation, and 2 minutes will be for the panelists to ask any questions if they want to ask. And to keep things under control, I'll have to stop the presenters, poster presenters at 3 minutes time so that we can give everyone equal chance to present their work. There are a couple more housekeeping things I'll describe. So everyone except the presenter or the panelists should keep their Zoom on mute, and please make sure that your camera is off as well. If you need to ask any question, you can put it in the chat box, or you can raise your hand and we'll give you an opportunity. If we cannot give you an opportunity during the presentation, we'll give you an opportunity at the end.
Assalamualaikum.
Walaikum Salam, Dr.
Yes.
Dr. Arva will be starting the session at 5:15 p.m. Do you have your poster presentation ready, or do you think you'll be able to put it on slide?
Actually, we mailed the slides. So I have not. You want me to open that slide?
No, just keep it ready. So once we start, then you can load it. If you have any problem or any trouble, just let me know. Okay. If the panelists and the judges are happy, we can start the session a bit early. Kindly let me know if you're happy for us to start, and I'll ask Dr. Arva to put on the screen share.
Yes, that should be fine.
All right. Okay, Dr. Arva, please go ahead and you can share your poster, and then we'll begin. We'll time you.
All right, I have started screen sharing.
Yes, you may begin. Dr. Arva,
Can everybody see the screen?
yes, we are able to see your screen.
Should I start or?
Yes, please do.
I'll start. Okay. Assalamu alaikum, everyone. I am Dr. Arva Hatem, and the topic of my research was reducing lower extremity amputations after the introduction of a multidisciplinary team in people with diabetes. Diabetic foot ulcers leading to increased morbidity and lower extremity amputations is one of the common complications of diabetes. And diabetic foot ulcer is a multifactorial disease. So multidisciplinary team approach has been shown to improve the outcomes of diabetic foot ulcers. So the objective of my study was to compare the outcomes of diabetic foot ulcers after introduction of a multidisciplinary team in terms of lower extremity amputation. This study was conducted at the Foot Clinic of Buckeye Institute of Diabetology and Endocrinology. And at Bite, the first foot clinic was basically initiated in 1996 under a single roof with a diabetologist and a diabetes educator. Later on, step-by-step modifications were done, upgradation of services and training was there, and there was addition of a multidisciplinary team through addition surgeon, interventional radiologist, cardiologist, the impact of a multidisciplinary team. Patients coming up with diabetic foot ulcers at the Foot Clinic were included from 1997 to 2020. They were divided into two groups. Group A consisted of cases before the introduction and addition of a multidisciplinary team, that is from 1997 to 2006. While Group B consisted of patients after the training, after the addition of a multidisciplinary team from 2007 onwards to 2020. And then outcomes in terms of lower extremity amputations of diabetic foot ulcers were assessed between the two groups. We could see that there was a decreasing trend of overall amputation from 27.5% in the initial years
30 seconds remaining
to 10% and then to just 4.6% by 2020. Overall, there was also a reduction in the major amputation and minor amputation rates from 10.2% to just 1% major amputation was there. So to conclude, my multidisciplinary team approach has a significant impact in reducing the lower extremity amputations in people with diabetic foot ulcers. Thank you.
Thank you, Dr. Arba. I'll ask my panelists to kindly ask any questions if they have for you. Dr. Turrab and Dr. Qasim.
Thank you, Dr. Arba, for doing this. I'm not clear that who makes your MDT team, and the rates you have said they have decreased. They have decreased because just purely because it's the MD team, or is it because you have been more aggressive with the vascularization and intervention by radiologists?
No, that is a part of they involved as a part of multidisciplinary team setup only. Initially, when it was only a diabetologist and a diabetes educator, we had a very high rate, obviously because of lack of awareness or lack of training, specialized training as well. But later on, when there was specialized training under international experts, of our doctors, of our diabetic foot care team, and there was addition, with multidisciplinary team, we mean that there was addition of orthopedic surgeons as well. We had on board interventional radiologists, cardiologists, vascular surgeons, footwear specialists, so that we could treat diabetic foot ulcer as a whole. The patient was having each and every opportunity at our own clinic, at our setup, so that it was easy for the patient.
Thank you ever so much. Thank you. And how frequently do you guys meet? Is it once a week, once a month, or how often does the team meet?
The team actually they are having OPDs at a setup. So within a week they all meet because they have different days and different setups, and then we are referring the patient at our own facility only to the patient.
Just to be clear in my mind that we do not meet in one room where everybody is going to refer it in between, yeah?
No, we are just sending them notes, and then if there is any specific or particular case, so we do.
Right. Okay. Thank you. No more questions.
Thank you very much, Dr. Arba. That's all.
We do hold a meeting with them.
Okay, so our next.
Stop sharing.
Yes, please do. Our next presenter is Dr. Qasim Mehmood. Dr. Asif, please unmute yourself.
I'm here and I'm going to share my screen.
Thank you very much.
Present my poster. Sorry, wait, okay. Okay, let's start. Should I start?
Yes, you're okay. Yes.
Okay, I'm Dr. Qasim Mehmood. I'm going to present an experience of CT scan services in 20 districts of Punjab under a central reporting system through public-private partnership. You know, the CT scan is an integral part of diagnostic modality services in the health sector. And before 2017, most of the districts of Punjab were deprived of this essential service. In 2017, Health Department and Government of Punjab decided to install this service in all of these peripheral districts, and contact was made with the private firm to install and operate this independently in these district area. The barrier to continue this project was that unavailability of trained and qualified radiologists, technician and technologists in these areas. To overcome this barrier, a proposal was made to establish a central reporting system. And after this government allowed, this private firm installed the PACT system. And through this remote area were connected with the central area where these radiologists, qualified radiologists, were available. So the aim and objective of this project was to establish a CT scan network throughout the Punjab, especially in the remote areas, so that the patient can be facilitated with this essential service, trained to radiologists with and familiar them with this teleradiological service, and of course provide the facilities to the patient at their doorstep. 20 centers are established in remote rural district of Punjab, and these centers are run and supervised by the private firm and their department, and these are governed by the private medical management unit of Government of Punjab. Trained technician and technologists, they are doing the CT scan according to the standard protocols, and these CT scan images are transferred. DICOM images are transferred to the central area through the packs where the radiologists are available. So the reports are sent back within 3 to 24 hours. You can see the result where the number of the CT scan are rising. So I will conclude that by incorporating the new technology, we can connect the rural areas with the central area where the human resources are sufficient, and we can fulfill this deficiency of trained staff and medical staff in the rural area. Thank you very much.
Dr. Asif, thank you very much. Your time is up.
So thank you. I've got a couple of questions for you, if that's okay.
Yes, I'm okay.
Mainly it is about the time lag. So the time appears to be quite a long time, 3 to 24 hours. And I was wondering, was there a mechanism of prioritization? That's my first question. And the other was there any quality assurance, like were these peer reviewed, these reports? And the third question is that was the service 24/7?
Yeah, the first one is that the time was basically, if we compare it to the tertiary care centers, where due to overburden of radiologists, the time is most prolonged. It's usually 3 to 4 days. And this step, by reducing this time, this is 2 to 3 hours for the emergency and 24 hours for the routine patients. And the second question was that this center works in 3 shifts for 24 hours, 7 days in a week.
And the question was about quality assurance. Has there been any efforts? Have there been efforts done to assure the quality?
The random reports from the each centers are reviewed by the few radiologists. These reports are picked by randomly, and they are reviewed by an independent other radiologist. The reports are counter-checked by a second radiology opinion.
Okay, right. Okay. And lastly, has there been an audit done to see whether it has changed any outcomes for the patients?
Yeah, it has been a paper is under process, and we are going to assess the economical and health facilities in the rural areas. And this is done by direct questionnaires through patients and the doctors working in these areas.
Okay, thank you very much. Thank you.
Thank you very much.
Thank you very much, Dr. Asif. I've got the next presenter, Dr. Azhar Hussain. I cannot see him in the session. If you are here, kindly raise your hand. Otherwise, we'll move on to the next presenter. Dr. Azhar Hussain. Okay. So next presenter is Dr. Ali Hassan. Ali Hassan, I'm giving you the permission. Kindly
Hello.
Unmute yourself.
Hello.
We can hear you.
Can you hear me?
Yes.
Yes, we can hear you.
Kindly upload my slide.
Yes, you can share your screen, please.
Do I have to share my screen?
Do you have your presentation with you? If not, let me see. I received a few. I can help you with it.
I haven't got it at the moment, please.
Okay,
I had got
let
a
me have
mail
a
that
look.
you will upload it on.
Okay, just give me a moment. Okay. Okay. Ali, are you able to see the screen?
Yes, I can.
Okay, you can start.
Assalamu alaikum. I'm Ali Hassan. I'm in final year MBBS in King Edward Medical University. Today, the topic of my presentation is hepatocellular carcinoma in HCV-related cirrhosis after sustained viral response. As all of us know that HCV is a highly prevalent disease all around the world. Globally, 58 million people are infected with HCV, with 1.5 million new infections per year, according to WHO. Pakistan has the second largest burden of HCC hepatitis C globally, with a nationwide prevalence of 4 to 8%, as been reported in different studies. Historically, HCV was treated with PEG interferon alpha, and in 2013, sofosbuvir was also introduced. The new European guidelines of European Association of Study of Liver recommends that treatment of HCV should be done with sofosbuvir along with 3 other direct-acting antivirals plus ribavirin to achieve the sustained viral response. Sustained viral response is undetectable viral load after 12 weeks of treatment withdrawal. In our dual-center retrospective cohort study, we determined the rate of HCR after 12 weeks of administration of sofosbuvir, daclitazepine with ribavirin therapy to our patients. Patients were selected on the basis of PCR-proven HCV, and treatment was done for 12 weeks of total duration. And we did follow-up after 12 weeks of treatment withdrawal. The mean follow-up time was around 34 to 36 weeks of the patients to counter for the doubling time of HCC. And in a study, we determined that the SVR rate was achieved in 94% of our participants after completion of triple therapy. And the incidence of development of HCC was then calculated it was 40% of our patients who didn't achieve SVR did develop HCC later in their follow-up. Can you please table it?
Yes, please, sir. Please continue.
HCV infect, and 94% of the patients did achieve SVR, and a total of 81 participants were detected to have SVR after 12 months of treatment withdrawal, and among those 81, just 2 patients developed HCC. On the other hand, there were total 5 participants who didn't achieve SVR, and 2 patients among those 5 developed HCC, almost 40%. And upon binary logistic regression, it was shown that 66% risk is decreased with the achievement of SVR for HCC. So, concluding my topic, I would say that in Pakistan, the rate of achievable of SVR is exceptionally well, has been reported in other studies around the world. While the triple
so
therapy
your time's up. It's time for questions now. Thank you.
Are you ready for questions?
Yes.
Okay, so basically, I'm just trying to understand the premise of the study,
Yes.
that we achieved more SVR in Pakistan as compared to other countries.
No, it is just on the same as been reported in international data. It
Right.
was comparable to that data.
It's comparable. So
Yes.
what was the need for this study in that, because we were using standardized protocols? So what was the importance, or what was the need of this study?
Previously, there has been no study been done in Pakistan regarding the achievement of SVR, and also there was no study done to study the incidence of HCC after achievable or non-achievable of SVR in patients who were given the therapy for complete duration.
Okay, so what are the barriers for achieving SVR? Is it the cost of medication, or is it not appropriate chemotherapy, or not being able to attend services?
In Pakistan, as you know, there are certain behavioral and psychological issues and socioeconomic barriers are there as well. So they combine a lot of multiple effects. I would say that multiple factors affecting for this.
So did they did this study reflect on that? Did it disseminate this, that SVR is possible in this population, and therefore we should make more efforts to standardize our protocols and offer the public this ability to be able to achieve SVR? Was there any effort made out of this study, the conclusion of this study?
I don't. I won't say that we actively did something after that.
Okay. Are you planning to do anything?
Yes, we are. We are trying to do this to have more people being registered for these treatments and help them get through the therapy, whatever the barriers are. Mostly the people, socioeconomic barriers are a large chunk of the patient. They can't even afford the medicines for 12 weeks, and it's quite costly medication. So we are trying to help those.
Okay. All right. Thank you very much. Thank you.
Thank you.
Thank you very much for presenting, Mr. Ali Hassan. We'll move on to the next presenter. Do we have Dr. Hafiz Anjum? Or is it Anjum Hamid who's presenting next?
Anjum Hamid is there, I think.
So I've got next presenter name as Hafiz Anjum. Is it the same person or he's not here? I've got an Anjum Hamid here. I don't know if they're the one who's presenting. If not, then we will move on to the next one. Okay, the next presenter is Iram Amir. Have you got Iram Amir in the session?
Assalamu alaikum. Am I audible?
Yes, you are.
May I share the screen, please?
Yes. Do you are we able to share or? All right.
Is it visible now?
Yes, it is visible. Please continue.
All right. Assalamu alaikum. Good afternoon to the respected jury members and to the audience. I'm Dr. Iram Amir. I'm representing the Academic Department of Psychiatry and Behavioral Sciences from King Edward Medical University. So our study aimed to explore and understand the psychiatric symptoms and stigma that was experienced by suspected or confirmed COVID patients who were quarantined in Mayo Hospital, Lahore. We sought the IRB approval, and after that we designed a mixed method study, which was conducted between April to May 2020. We utilized convenience sampling. As a result, at that time, 160 patients were admitted. 114 were adult patients. The rest were pediatric population. We published another article related to that. So the 114 adults were interviewed by video-assisted phone calls due to the disease's contagion. We used validated scales for stress, adjustment, depression, generalized anxiety, insomnia, and stigma. A few open-ended questions were also asked about the patient's expectations and their needs while they were in isolation. We ran descriptive analysis for the demographic details, chi-square test for gender and differences between gender and the duration of hospital stay, and independent t-test was used to analyze the mean scores between the groups. For qualitative assessment, we used content analysis, and the authors then coded the verbatim of the individual patients, and themes were the themes were concluded out of them. So as a result, out of the 114 patients, 90% were confirmed cases of COVID-19. 54% of the participants were men. Mean average age was 38 with a range of 18 to 67 years. The duration of hospital stay at the time of admission approximately was 7 days. The most common psychiatric symptoms reported were irritability, anxiety, followed by insomnia. According to DSM-5 criteria, 16% of the participants had depression, 18% had anxiety, and 30% had insomnia. We saw that men reported more frequency of symptoms. However, women had higher mean rates for depression, anxiety, and particularly insomnia. And widespread experiences of stigma were reported, particularly with concerns about public attitudes. And the main themes that were then devised were social stigma, rejection, humiliation, breach of trust, financial problems were also reported related to the COVID-19 experience. As a result, we concluded that we needed to incorporate the psychological services very early at the acute phase of COVID-19 illness for prompt recognition and then management of further psychiatric problems. Thank you very much.
Thank you, Dr. Aram. We'll move on to the questions now.
Aisha is asking questions. Aisha Saqib.
Is Aisha online or?
Yeah, I can see her.
Let me see.
Brilliant.
If she needs any help with unmuting Aisha Saqib. Co-host. Dr. Aisha, you can unmute yourself now.
Don't know if she can hear you.
Dr. Aisha, are you able to hear us?
Doesn't look like. I think I can ask Dr. Turrab to ask questions. Turrab, do you want to ask questions here?
Yes, I'll ask a question. First of all, thank you so much for presenting the study. You said that the psychiatric evaluation needs to be included quite early on in COVID pandemic, but how long did it take you to conduct the study and how it has become implemented in the COVID assessment? Is it for the patients who just come to hospital and get admitted, or is it being offered to people who are being tested positive for COVID as well?
Thank you so much for this question, sir. We conducted the study for a time period between April 2020 and May 2020. This was the first wave of COVID where initially we were receiving a lot of referrals. These were patients who were quarantined because of the government's advice. At that time, home isolation was not offered. So this is the time where people were having a lot of psychiatric problems related to adjustment and stigma. So the psychiatry department stepped in. We did a lot of interviews. We found there was an alarming rise of the psychiatric problems. So there and then we developed a liaison system between medicine department. When people were admitted, the psychiatric assessments were done at the time of admission. And even if they were picking up symptoms while during medical rounds, then the psychiatry team was employed, psychologists were employed. At this time as well, Mayo Hospital is the main referral system in Punjab, and psychiatry department is very active. We have pre-designed performers. We assess the patients in the isolation wards, and we do offer psychological help as well as medications. And if your question is, you asked if we are able to revise these, implement the results of these studies. I think it is. We were very successful in implementing because there were alarmingly high levels of insomnia, and then people were also becoming people with comorbid illnesses also were experiencing delirious symptoms. So at that, this is how psychiatry department is helping by advising medications and by counseling not only the patients but as well as the attendants as well.
Thank you so much. Is it time for a follow-on question, or are we short on time?
No. Yes, you can.
Yeah, so I understand that the Punjab and the central government developed this remote or telehealth service, especially with the COVID, which was a stimulus. So did you guys develop something
Yes, sir.
in relation to that?
So telemedicine has been a blessing in this time. We have, when the governor of Punjab, he started telemedicine department, telepsychiatry was also established. There's a separate counter for telepsychiatry, and we utilized, we used the telephone services. There was a separate mobile phone that was handed over to the department with a different contact number. It was publicized by social media. People from all over Punjab, not only Punjab, but all over Pakistan. And we also received some international calls because of the publicizing efforts of the university. So it was very easy to follow up with the patients because we did not have to go into the wards. We could just call them. Video-assisted phone calls were a very good source of communication between the physicians, the psychologists, the patients, and the attendants as well. And we have followed up with these patients and attendants.
I have to stop you there. The time is up, and we have to move on to
the
next presenter. Thank you very much. I've got Dr. Mada Fatma as the next presenter. Dr. Fatma, if you can hear me, you can unmute yourself.
Yes, Assalamu alaikum and good evening, everybody. I am here. Should I start?
Yes, you can.
Or would you be sharing it?
Yes, you can screen share. I understand you are presenting 2 posters. Is that correct?
Yes. Okay, I'll start sharing it. Yeah. Okay, Assalamu alaikum. I am Dr. Mada. Can everybody see my screen?
We can see that
not yet, but I think it's trying to do it.
Yes, we can see it now. Dr. Mada, you can continue. We can see your screen now.
Okay. I'm Dr. Mada Fatima, a postgraduate resident of psychiatry from Mayo Hospital. My presentation is entitled Barriers and Adverse Event and Error Reporting at Secondary Level DHQ Hospitals of Punjab. Avoidable patient harm that is caused by adverse events and medical errors is one of the 40 leading causes of global burden of disease and one of the 10 leading causes of death and disability worldwide. Pakistan lacks a national level patient safety database. However, Healthcare Commission's minimum delivery standards have set indicators and scoring related to ADR and sentinel event reporting. This was a cross-sectional study that aimed to identify barriers faced by healthcare providers according to their perceptions in event reporting at the DHQ hospitals. It was conducted from July till October 2020 by using a questionnaire that was designed after a thorough literature review, research consensus, and pilot testing at the Tehsil Headquarter Hospital. 2-stage sampling was employed. In first stage, convenience sampling was used to select 2 DHQ hospitals, and stratified random sampling was used to collect data across different groups of healthcare providers, while purposive sampling was used for hospital administration. Currently employed healthcare staff involved in direct patient care, aged 20 to 60 years, was included, and those who had been working for less than 6 months at the hospital were excluded. Reasons: Swiss cheese model of error and incident causation is the theoretical framework of the study. SPSS 23 was used for data analysis. Chi-square test, descriptive statistics, and Crystal Wallis test were used for data analysis. Results showed that nearly half of the participants, 48.5%, never had any patient safety courses or trainings. Majority of whom were general duty doctors, and interestingly followed by hospital administrators, while pharmacists had the highest proportion of those who had such trainings. 33.9% stated that there was no mandatory system of reporting at the hospital, while 1/3, 26.7%, were not aware if there was any. However, 80.1% affirmed that there was such events could be reported voluntarily, and 59.9% had affirmed.
30 seconds remaining.
Okay, organizational and cultural factors were the major barriers, followed by fear-related barriers, which were perceived as barriers by 55.7%, followed by 49.9% of the participants. Attitudinal and emotional and knowledge and skills-related barriers were least perceived as barriers. Age groups did not have any effect on perceptions of organizational and cultural factors. This study has recommendations related to patient safety-related capacity building and skills enhancement trainings at DHQ hospitals, in addition to transformation of the patient safety culture to a just and blame-free culture, aimed at ensuring accountability accountability for the strengthening of healthcare system to deliver services. In addition, incentive-based reporting systems can be introduced, both mandatory reporting system at the level of regulatory bodies and voluntary reporting system at the level of healthcare organizations or hospitals, linked to key performance indicators of the healthcare providers. Thank you so much.
Thank you very much. So are you ready for questions, Mada?
Yes, I am.
Okay, so thank you very much for presenting, and I think it was well timed, and it's something that doesn't get talked about. So my question to you was that as a result of your findings, have you made any suggestions for staff training about safety and about upskilling the staff as well as the administration about protocols, etc., to protect the staff, patients, and everybody else coming into the hospital?
Yes, exactly. I have. As far as the patient safety related trainings are concerned, I have recommendations related to AHRQ's team steps trainings, which are the teamwork strategies for increasing efficiency and effective patient safety. Basically, in addition to that, communication skills training, event reporting, such as sentinel event reporting systems can be introduced, the concepts of root cause analysis as well. As far as SOPs are concerned, these SOPs are already there, but the problem, the need of the hour is that they need to be circulated among the healthcare providers because nursing staff was at the front line of reporting, so they knew about these SOPs, while frontline doctors or the general duty doctors and consultants did not. So yes, these recommendations have been put forth clearly. Thank you.
Do you think they should become part of medical curriculum? Have you made any suggestions?
Yes, I have, as a part of policy reforms as well as institutional reforms, because we need a safety curriculum in our medical education system, both at the undergraduate and as well as the postgraduate levels. Because when I was conducting my study, I got to know that most of the participants did not even know the basic definitions of near misses, slips, and no harm events, even though these were occurring on daily basis at the DHQ hospitals.
Okay, and larger hospitals as well.
As well, of course.
All right. Okay. All right. Thank you very much. Thank you.
Thank you. Time is up for this one. Dr. Mada, you can load up your next poster.
Okay, I'm going to do this. Okay, my next presentation is entitled Mehreen Nasir, Assessment of Patient Safety Culture at the Secondary Level Sector District Headquarter Hospitals of Punjab. Patient safety is the prevention of avoidable and unnecessary harm to patients linked to healthcare and minimization of this, the risk of this harm to minimum possible. And now we know that there is a physical component of healthcare system as well as the latent and the subtle areas, which include the shared norms, values, and patient safety perceptions of healthcare providers in addition to attitudes and perceptions, which is understanding these is mainstay to identifying the latent organizational and system failures leading to patient harm, because patient safety is the integral component of technical healthcare quality, and unsafe care is costing millions and trillions of US dollars even to the healthcare system, not just the patients. This was a cross-sectional study that utilized 42 items, hospital survey on patient safety culture, which has been designed by US Agency on Healthcare Research and Quality. It is an internationally validated tool. It was pilot tested at the Tehsil Headquarter Hospital, then through two state sampling, two DHQ hospitals were selected, followed by stratified random and purposive sampling for healthcare provider groups. Currently employed healthcare workers who were involved in direct patient care 20 to 60 years were included. Those who had been working less than 6 months were excluded. SPSS 23 was used for analysis. Crystal Vallis test, Spearman's correlation, and binary logistic regression were used. The mean age of respondents was 32.5% plus minus 0.48. Majority were females, 20 to 30 years of age, nursing staff, and general duty doctors. Now, the mean positive percentage response rate for patient safety culture dimensions was 40.2%, which is below the set standard of US AHRQ, which is 50%. The highest scoring, and interestingly enough, the only area of strength was teamwork within units, which scored 81.5%, followed by organizational learning and continuous improvement and supervisor and manager expectations. All other patient safety dimensions, including staffing, communication mechanisms, feedback and communication about errors, management support, and and patient handovers were in need of in dire need for improvement, were weak areas of culture. More than around 2/3, 69.7% had not reported any single event over past 1 year. Conversely, majority gave acceptable 60.3% scores, 35% favorable, and only 4.7% unfavorable to the patient safety in their work areas. General duty doctors and specialist doctors gave more unfavorable overall patient safety scores, mainly from the medicine and allied
30
departments,
seconds
followed by
remaining.
Okay, there was also a positive correlation between different patient safety culture dimensions, and it was also, except for staffing, and it was also seen that each 1 unit improvement in teamwork within unit also increased the number of events that were reported and overall patient safety grade. Now I have recommendations at the level of policy reforms, institutional reforms, and future research. As universal healthcare is impossible without safe healthcare, and which is inconceivable without just and non-punitive patient safety culture, which requires synergistic and collaborated efforts of policymakers, hospital administration, and clinical staff. A positive culture with clear accountability, trainings of healthcare providers, and effective implementation of interventions such as root cause analysis is integral for safe care. Thank you so much.
Thank you so much for presenting this. My name is Dr. Turrab. Do we have systems in Pakistan where these events are reported or logged? You have mentioned about root cause analysis and sentinel event reporting in ADR forms. I left Pakistan some time ago, but did we have these kind of forms in place that
Yes,
these
sir.
are reported, or this is just your study?
Yes, sir. These systems, sentinel event reporting, as well as ADR reporting, are even the indicators and minimum service delivery standards of Punjab Healthcare Commission. They are also in effect at the DHQ hospitals, but the problem is with sustainability. The problem is with the proper SOPs and protocols that lead to review meetings and that lead to the proper follow-up of these reporting systems. Because there was even computer-based reporting system of ADR reporting, which was done by pharmacists. And except pharmacists, nobody knew about that. Other healthcare provider groups like doctors and the nursing staff. And interestingly enough, sometimes among the administrators as well, this knowledge was lacking. So not root cause analysis. This is in practice at certain private sector hospitals, but sentinel event reporting and ADR forms are there, but problem is with effective implementation.
Thank you, Mother. And your background is, correct me if I'm wrong, is it psychiatry, or is your background health economics, or what's
Sir,
your
I have
background?
done MPhil in public health before I
Okay, that's fine. So that's brilliant. Thank you so much. Well done. Thank you.
Thank you, sir.
Thank you very much, Dr. Madha. For the next presentation, I've got Dr. Maham Mansoor. Dr. Mansoor, if you can hear me, kindly raise your hand. I'm not able to find you in the session attendees list. Okay, Dr. Maham Mansoor, are you able to hear me? Kindly raise your hand. Otherwise, we'll move on to the next presenter. Okay, I think she's not here. Next presenter is Dr. Muhammad Ammar Amjad. Dr. Amjad, you can unmute yourself and we'll start with your presentation.
Thank you, Haris. I'll just share the screen and then we'll start.
Thank you very much. I think let me end Dr. Madha's screen share.
So can we see the screen?
Yes, we can see your screen. Please start.
Assalamu alaikum. I'm Dr. Ammar Amjad. I'm currently working in the Department of Anesthesia at Shaukat Khanum, Lahore. And I'll be presenting my triple-blinded randomized controlled trial today. To start off with the background of the study. We all know that cancer is one of the leading causes of death worldwide, with breast cancer being the most common in females. The burden of disease is so high that approximately 2.3 million new cases were reported in 2020 alone. Although different options like chemotherapy and radiation are available, surgery still remains one of the cornerstones of the treatment. And for us as anesthetists, pain optimization in the perioperative phase is of utmost importance. So the arsenal that we have to control pain includes non-opioids, opioids, nerve blocks, and local wound infiltration. Among these options, opioids remain the topmost choice as they are excellent painkillers, but they also come with a lot of side effects, which includes pruritus, sedation, and even respiratory depression. So there was a desperate need to find an adjunct which could decrease the opioid consumption, and this is where dexmedetomidine comes in. It is a relatively newer drug which has shown a lot of promise recently. So in light of all of this, we devised this triple-blinded randomized control trial with 2 groups of 30 patients each. One of them received bupivacaine, while the other was infiltrated with bupivacaine plus dexmedetomidine 10 minutes before the incision. Our primary objective was to measure the total perioperative morphine consumption, and the secondary objective was to measure the PACO discharge time between the 2 groups. The inclusion and exclusion criteria are listed in the e-poster, so we won't go into the details of that. So coming to the results, the total morphine consumption was 7.5 milligrams in group B as compared to 5.48 in group D. This difference was statistically significant with a p-value of less than 0.001. Coming to the secondary objective of the study, the mean PACO discharge time for group B participants was 116 minutes as compared to 105. This shows that although dexmedetomidine is a sedative, it does not prolong the PACO discharge time. So to summarize, the addition of dexmedetomidine not only decreased the opioid consumption, it led to a better pain control, a shorter PACO stay, and an overall improved patient satisfaction. I would like to end my presentation with a quote from Buddha that pain is inevitable, but suffering is optional. So let's work together to end this suffering. Thank you very much. And I'll be happy to take any questions.
Thank you, Dr. Amar.
Thank you, Amar. I'm Aisha. I'm going to ask you some questions for presenting this poster. So how did you randomize which patient is going to go to which arm of your study?
So all the patients, first of all, we inducted by convenience sampling. Then all the patients who were coming, they were randomized using an online software by a fellow of the anesthesia department. He was independent from the study group. So there were 60 patients. He would randomize the patients, then he would make the drugs, label them according to the name and MR number, and then they would give us a code that was labeled on the syringe. And this is how the data was collected. So once the data was collected and analyzed, then the same guy who randomized and blinded the study, then unblinded, and then we went to know about the results.
Okay, thank you, Amar. My next question is, did you notice any adverse effects from dexmedetomidine? Because usually it's used in intensive care settings for patients who are intubated and ventilated. You were using this for patients who possibly were post-op and not intubated and ventilated anymore. Were there any side effects that you noticed, or were they part of the trial?
Yes, so we were actively looking for the side effects, notably hypotension and bradycardia, which is notorious for dexmedetomidine. But for these 60 patients, we did not find any adverse events related to dexmedetomidine.
Thank you. And what were the possible biases? Do you think the patients knew that they are on dexmed, or any possible?
No, so this was a triple-blinded study, so not the patient, not the doctors, the surgeon, no one knew about which drug they were getting.
Thank you very much. That's very helpful.
I think Dr. Turrab, Syed wants to ask a question. Aisha, if that's okay with you?
Yes, please do.
Turrab?
First of all, thank you so much, Tavinda, and thank you so much, Amar, for doing this study. 2 questions. One is, am I correct in understanding that you injected dexmedetomidine into the wound, or did you give them intravenously?
So it was given into the wound. So the standard practice is that the surgeon comes in and they mark out the incision lines, and they inject bupivacaine into the wound for local infiltration. So we added dexmedetomidine to see if it would decrease the opioid consumption, and it did.
Sure. And second question is that, how did you come up with that idea, or is there any paper? Because I know I routinely give bupivacaine, and I give adrenaline with bupivacaine, so the adrenaline can make the bupivacaine stay in the wound for longer, so it can have a longer analgesic effect. So where did this idea came that this is intravenous sedation, isn't it, if I'm not mistaken?
Yes.
And how did you come up that we should inject this into the wound rather than giving it what is normally licensed to be in? Was that considered off-license use, and did you have any problem when you were going to do that study through your local ethical review process that is unlicensed use?
Thank you, Dr. Turrab, for the question. So, yeah, you're right that the drug was used for ICU sedation, but I think from the last 4 or 5 years, it has been used as an adjunct to local anesthetic. And even in, there is a lot of data in the West, but also in Pakistan, it has been used for pediatric hernia patients. And I think it's a very, what would I say? It's in the literature now and has been there for the last 4 or 5 years. So it was not the first time that we were doing it, but it was the first time in our population and in cancer patients. This was the first one that we did it.
So previously it was used in non-cancer patients, but this is the first time it's been used in cancer patients.
I'm not sure about the international data, but in Pakistan, it was used for the first time in cancer patients, yes.
Lovely. And your local ethical review process was happy for you to carry out this?
Of course, this was passed through the scientific review committee and the institutional review board, and of course, then this trial was started.
Lovely. Thank you, Abid. Thank you.
Thank you very much.
Thank you very much, Amar, for the presentation. Amar had the last presentation. I think we left out 2 presenters who were not present initially. I think Azhar Hussain.
They're back actually.
Yeah.
Yes.
So are you able to?
Yes, Dr. Harris.
Okay, I'll make you the co-host if you can. All right. I've given you the permission. Azhar, you can share your screen and we'll get on with the presentation.
Okay. Do you see my screen? Can you see my screen, please?
Yes, we can see your screen. Please continue.
Okay. My name is Azhar Hussain. I'm student of final year MBBS from Amiruddin Medical College, Lahore. Currently, I'm working as research officer, Gummal Liver Transplant Program, Sindh. And today's topic of my presentation is safety of glucose 6-phosphate dehydrogenase deficiency in donors and its safety in living donor liver transplantation, especially for right lobe hepatectomy. So as everyone do know that G6PD deficiency is the most common human enzyme deficiency. And data that has been reported in various studies from Pakistan concludes its prevalence ranging from 2.5 to 9%. So effectively, according to the guidelines of living donor liver transplantation, that is G6PD deficiency is contraindication for living donor liver transplantation, as there is no safety data available on its safety. So we were effectively eliminating 4 or 5th of our donor, which was whose recipient were in dire need of liver transplantation, because we were following the guidelines. So our center decided that to have conduct a study by providing all the risks and complication detail to the donors who were deficient, so that we can pursue on for hepatectomy and then liver transplantation. So we designed this prospective study and we compared the outcomes of 15 G6PD deficient donors with matched cohort of 39 non-deficient donors. And post-operatively, we looked for their post-operative hemolysis, particular and associated need of blood transfusion. As we know that G6PD deficiency is associated with blood transfusion whenever it is exposed to various oxidative stress events. So reported prevalence in our data was 4.4%. And out of the 15 G6PD deficient donors, 4 were of class 2 deficiency and 11 were of class 3 G6PD deficiency. And for the audience sake, G6PD class 2 deficiency has never been studied in literature. And this is the only first prospective cohort study which is giving the safety data regarding class 2 G6PD deficient
30 seconds
donors.
remaining.
Yeah. So 3 donors developed biochemically evident hemolysis and there was no blood transfusion given to any of these donors. They were managed symptomatically with fluid transfusions. And through this study, we conclude that G6PD deficiency, especially class 2 and above, should not be considered a contraindication for right lobe donation in situation where legal donor, which is non-deficient, is not available. Thank you so much.
Thank you very much.
Yes, I was planning to ask questions. So first, thank you ever so much, Azhar, for doing the presentation. My name is
thank you so much.
Yeah, Dr. Turrab Syed. So tell me, how do you diagnose people with G6PD deficiency? Do you test every single liver transplant before doing that? And were you not doing any liver transplant prior to doing the study on people who were coming up as positive for G6PD? And second question is that, is the incidence different in Sindh because you've got a bit of a Makrani population, but Gambit is probably, I think, is more in central Sindh. Probably you wouldn't have that many people with Makrani heritage over there, or do you?
Okay, coming on to the first question. According to the living donor liver transplantation right lobe hepatectomy guidelines and procedure, the routine labs evaluation includes G6PD among the rare labs, G6PD deficiency and other thrombophilia profile. So in every donor, we use to perform G6PD qualitative. And on the basis of the qualitative result, whether G6PD deficiency present or absent, it is available only in one lab, that is Khan lab, Karachi. So those patients who were deficient on qualitative study, we went on a step further by paying from our pocket from institution research fund, and we move on to have quantitative data, the quantitative amount of G6PD deficiency, and from there we consulted our consultant hematologist and our head of the department of hematology department and bone marrow transplantation for the particular classification, the WHO classification of each of these deficient donors. Like this deficient donor is deficient with G6PD deficiency, but it falls in weight class 2, class 3, class 4. So after this, we collected the data of these donors. First, second question. Coming on the second question, Gambit liver transplant program is actually the only public liver transplant program which is performing around 6 liver transplants per week, and previous year we transplanted 200 transplants. So we are covering population from entire country. Yeah, but as Sir said that there are patients from Makran, Balochistan. So
Dr. Azhar, I'll have to stop you.
That
Sorry,
is why
your time is up.
Yeah, sorry.
Okay. Sorry about that. I'll have to cut short. So now we will try to move on to the next one. Dr. Maham Mansoor, if you are present, kindly raise your hand and we'll give you a chance to present your poster. I think she's still not here. As per the list that we had, these were all the poster presentations, unless somebody else, I think
Dr. Arwa Hatim. I think there's Dr. Arwa Hatim. She's present, and it was her first poster was hers, wasn't it?
Yes, it was. Yeah, she presented. Yeah,
Okay, fine,
Dr. Arwa was the first one.
Okay, fine.
Okay, I think this concludes our poster presentation.
Yeah.
I would like to thank all the presenters and all the panelists for asking all these questions. I think it was a very good activity. We'll be ending the stream on this session. I think my colleague has already posted a link for the channel 1. So we'll ask the attendees to move to channel 1, and the results of the poster session will be announced there at around 7 p.m. And I will give a chance to the panelists if they would like to add something. All right, thank you very much. Thank you, Dr. Turrab. Thank you, Dr. Tavinda, and thank you, Dr. Aisha.